Hi there. This presentation is on sepsis and septic shock. You'll find the corresponding information under Module 1, Unit 1, Topic 4. Having reviewed the components of normal inflammatory response, it is important to take into consideration what is happening in the pathological process of sepsis and septic shock. This presentation will focus on the pathophysiology of sepsis and septic shock and briefly discuss clinical presentation and treatment. A more detailed discussion of etiology, pathophysiology, clinical presentation, and treatment of septic shock will be presented in Module 6. A recent update to the definition used to describe sepsis and septic shock has brought clarity to these terms with the hopes of earlier recognition and treatment. Sepsis is now defined as life-threatening organ dysfunction caused by a dysregulated host response to infection. Septic shock is defined as a subset of sepsis in which underlying circulatory and cellular metabolic abnormalities are profound enough to substantially increase mortality. It is important to note that once the systemic inflammatory response syndrome, or SIRS, was considered part of this continuum of sepsis, it is now understood that SIRS reflects an inflammatory host response, which is typically beneficial and adaptive, whereas sepsis involves activation of both pro-inflammatory and anti-inflammatory responses and is not an adaptive response. It is important to note that SIRS may occur in the absence of infection or sepsis, with conditions such as multiple trauma, surgery, burns, shock, and pancreatitis. In order to provide early treatment of sepsis and septic shock, we need to be able to identify those patients who have it. Because of this, the diagnostic criteria has also been updated. The criteria for sepsis is evidence of infection or a strong suspicion of infection and a quick sepsis-related organ failure assessment, or QSOFA, of greater than 2. Specifically, the QSOFA looks at respiratory rate, mentation, and blood pressure. The criteria for septic shock include those for sepsis, along with the requirement of vasopressors to maintain a MAP greater than or equal to 65 millimeters of mercury and a lactate greater than 2 millimoles per liter, despite adequate fluid resuscitation. Thinking back to our review of the normal inflammatory response, it is important to remember that it is very effective against injury or invasion at a local level. In sepsis, however, this response is on a systemic level, causing massive vasodilation, excessive permeability, systemic activation of inflammatory cells, mediators, and coagulation factors. Ultimately, all these normally adaptive processes are going on simultaneously around the body, and eventually compensatory mechanisms become overwhelmed. The end result is a massive systemic vasodilation due to tumor necrosis factor, the complement system, and nitric oxide, as well as microvascular permeability due to excessive amounts of complement kinine and other mediators that leads to a generalized edema and decreased circulating volume. We also see systemic cellular activation leading to vascular obstruction, tissue infiltration, and excessive mediator production and release. Lastly, the hemostatic system of the body favor a procoagulant state, causing the formation of microthrombi, compromising tissue perfusion and consuming clotting factors. Clinically, some or all of the following may be present. The blood pressure is generally low due to the decreased systemic vascular resistance, or SVR, from massive vasodilation. Despite this, we may see a normal or even high cardiac output, especially in the early stages of sepsis, because the compensatory mechanisms, which are facilitated by the stimulation of the sympathetic nervous system, increase the heart rate and contractility. This, along with the decreased afterload, reduces the workload of the heart and ultimately increases stroke volume. The patient's respiratory rate may also be elevated due to metabolic acidosis, which the respiratory system tries to increase by pH by blowing off CO2. So this is a compensatory mechanism. We can also see alterations in temperature, either high or low, which may also be seen with chills and rigors. Warm, flushed skin with bounding pulses can be seen in early sepsis. However, as sepsis progresses, the compensatory mechanisms may fail, leading to skin mottling, decreased skin perfusion, and poor capillary refill. Otherwise unexplained alterations in mental status are often early and sensitive indicators of an underlying sepsis and should be assessed and reported early. In later stages, as the cardiac output falls, evidence of end organ dysfunction such as decreased urine output may also be seen. Petechiae and purpura are indications of underlying thrombocytopenia and generally indicative of a poor prognosis. Elevated white blood cell count with increased bands, so greater than 10%, or what's called a shift to the left, generally indicate the presence of an infection as opposed to just an inflammatory response. With respect to laboratory findings, typically an increased lactate is evidence of a decreased tissue perfusion and the requirement of cells to move from aerobic to anaerobic metabolism. And it is actually mentioned as one of the diagnostic criteria for sepsis and septic shock. Elevated white cell count with that increased bands of greater than 10% or a shift to the left also indicates presence of infection. Thrombocytopenia may be present. Patients are often hyperglycemic due to the stress response, and outcomes are typically worse if this is not appropriately managed. Lastly, the mixed venous oxygenation saturation or central venous oxygenation saturation may be low due to increased tissue extraction, or it may be high if the tissues are unable to extract oxygen, the latter being a more ominous sign typically. Treatment of the patient with sepsis or septic shock, as with any patient, starts with airway, breathing, and circulation. More specifically, it is recommended that a fluid challenge of at least 30 mL per kilogram of crystalloid be given within the first 3 hours. This should be guided by frequent reassessment of hemodynamic status, such as heart rate, blood pressure, respiratory rate, temperature, urine output, arterial oxygen saturation, and normalization of lactate. The most recent Surviving Sepsis Campaign guidelines also strongly encourages the use of dynamic measures such as passive leg raises and pulse pressure variability, which have shown better accuracy in predicting which patients are likely to respond to fluid challenges. Further important interventions for sepsis and septic shock are to determine the source of the infection and treat it appropriately. Blood, urine, and respiratory cultures should be drawn as soon as possible and prior to antibiotic therapy, unless that would delay antibiotic therapy. Broad-spectrum antibiotics should be started as soon as possible and within 1 hour of diagnosis. It is believed that mortality can increase by as much as 7% per hour that antibiotics are not given. It is also important that the antibiotic given is appropriate for the infectious agent. So once cultures have identified the offending organism, the antibiotics should be narrowed to match sensitivity results. As sepsis progresses to septic shock, vasopressors are required to maintain a MAP of greater than 65 millimeters of mercury due to the massive vasodilation and the failing of compensatory mechanisms. Norepinephrine is the first choice and should be titrated using intra-arterial blood pressure monitoring. If norepinephrine is insufficient to maintain the blood pressure at 65 millimeters of mercury, vasopressin or epinephrine can be considered. Dopamine is not routinely recommended, but may be useful in certain subsets of patients, such as those with bradycardia. And inotropic medications such as dobutamine may be useful in patients with myocardial dysfunction, with signs of hypoperfusion. However, caution should be taken as dobutamine can worsen hypotension. Other supportive measures for the septic patient include mechanical ventilation, deep vein thrombosis prevention, blood product administration for generally a hemoglobin less than 70, nutritional support, enteral is preferred to parenteral, stress ulcer prophylaxis, corticosteroids for refractory sepsis, blood glucose control, and ventilator-acquired pneumonia prevention protocol. More on this when we cover pulmonary pathophysiology. So in summary, sepsis is characterized by a dysregulated response to infection and overwhelming systemic inflammatory response. Sepsis causes disruption of homeostasis through an uncontrollable cascade of excessive inflammation and coagulation with impaired fibrinolysis. This results in microvascular hyperperfusion and organ dysfunction. The magnitude of the disruption in homeostasis is influenced by the virulence of the causative pathogens and the host's response to the infection. Septic shock is a subset of sepsis, with hypotension refractory to fluid administration, requiring vasopressors, and is associated with multi-organ dysfunction and higher mortality. The underlying pathophysiology is a systemic inflammatory response that leads to massive vasodilation, increased capillary permeability, cellular activation and adhesion, and unbalanced hemostasis, all leading to intravascular volume depletion and decreased tissue and organ perfusion. Key aspects of clinical presentation include decreased blood pressure and SVR, and evidence of end organ dysfunction due to lack of tissue perfusion, such as altered mentation and decreased urine output. Lab studies show increased white blood cells with a shift to the left and an increased lactate. Treatment includes the ABCs, specifically a fluid challenge with crystalloids, antibiotics, and hemodynamic support as necessary. This concludes the presentation on sepsis and septic shock. If you have any questions regarding the material covered in this presentation, please contact your instructor.